Let's Talk About Kidneys takes a deep dive into the chronic kidney disease patient journey. We're here to inspire meaningful conversations and to help people living with CKD gain a full understanding of their disease. On today's episode, we hear from DNA patient Tiffany Archibald, a two-time kidney transplant recipient, and her DNA nephrologist, Dr. Cindy Corpier, as they talk about staying healthy and maintaining a post-transplant care plan. Thank you so much, ladies, for taking the time to sit down with us today. I can imagine that there are several factors at play when you're trying to ensure that you're staying healthy, Tiffany, in your recovery process, and that you, Dr. Corpier, feel like you have all of the data and information necessary to be able to make the best recommendations for the care of a patient like Tiffany, for example. So, Dr. Corpier, I'd like to start with you. How long have y'all actually known each other at this point?
We met in December of 2015. Tiffany was about 2 years out from her second living donor transplant, which was her spouse donated to her the second time, and she relocated into our area. And so, as happens, someone moves and they need to find new follow-up care. So she came to our practice in our North office around that time.
Fabulous. Well, now you get to actually formally work together. You're doctor-patient, but also formally colleagues.
Yeah. Yeah. I know. It's a bonus.
Yes. Fabulous. So at that time, being 2 years in terms of post-transplant, how often were you seeing Dr. Corpier at that point, and how has that changed over time?
I think that I was seeing her quarterly, so every 3 months. And that's pretty typical, the time frame that I was, out of my transplant. And also it goes into, how your labs look, because if there's something that alerts her, I would need to come in sooner than that. But for the most part, it was like every 3 months.
Every 3 months. Well, and so if someone's really just right out of surgery, what does that look like in comparison?
So typically now, in a fairly straightforward transplant, particularly a living donor transplant, the patient may go home at day 4 or day 5. This is dramatically different than it was 2-3 decades ago. But now patients go home very quickly, and so we begin seeing them in the clinic shortly thereafter. If you go home on Friday, you'll be back in clinic on Monday, have your labs done. And so we follow a pretty intensive schedule at our transplant clinics that the patient usually comes in for the first couple of weeks about three times a week, and then down to 2 times a week, and then down to 1 time a week, and then monthly out for the first several months, and then we sort of wean it off, shall we say, down by the end of the first year. We hope to be at a quarterly schedule. It very much depends on what's going on. If someone is having infectious complications or other problems, blood pressure issues, immunosuppressive complications, then we may see them more frequently.
I was going to say, so are some of these appointments like a quick in and out, or when you were going once a quarter, like, is it just a quick check-in, or is that something where you're continuing to do labs? Do you remember what some of those early conversations
It's definitely not quick, and then especially with Dr. Corpier, she literally, I've always had great doctors, but she's at the top because she's so detailed and she takes that time. And I know a lot of patients, when they're seeing primary care or other specialists, they just feel like it's a conveyor belt and the physicians are knocking on the door, coming in. But no, you go in. And for me as a patient, one of the things I always suggest is if there's something, you've changed in your diet or your energy or anything. So I always go in with notes in my phone so that I know that whatever she's going to address based off of my lab results and my urine and things like that, and, reviewing my medication, then I also have my own questions as well. So
That's a huge piece of it. I know for myself, from a patient perspective, I can go into a doctor's appointment and feel like I know exactly what they just told me and have a really great idea. So I leave feeling confident. And then I immediately realize that I seem to have blacked out and I don't remember anything as to what was discussed in this appointment. So, Dr. Corpy, I'm curious, do you have any recommendations for patients to be able to come into some of these appointments, to be able to make the most of them and help you as a physician?
I think that Tiffany's method, and it doesn't matter how you take your notes, right? Sometimes it involves bringing someone with you. Sometimes it involves now, we FaceTime with mama, or we FaceTime with the wife, or we FaceTime with whoever we need to, so that, two heads are better than one sometimes.
Yes.
But yeah, bring in, write things down if that happens to be a problem. The one thing I learned as a fellow a very long time ago is that the thing that is foremost in the mind of the patient is not necessarily at all the thing that's foremost in my mind. Okay. And so we have to address both things. So if, as mundane as it may sound, the thing most bothering the patient and the patient that I learned this on more than any other, it was constipation. Okay. Well, I was like thinking about the 30 lab tests that we're looking at, everything else, his immunosuppression, his meds, all of his, there's a whole long list of things we're looking at, but he could care less until I fix that. Or if it's pain, or if it's, nausea, or if it's problems getting medicine. There's a bunch of different things, or if it's sleep.
Yeah. Being able to have the open line of communication.
Right. And so I advise patients, if there's something that's bothering you, lead with that. Okay.
Lead with that.
Lead with it.
I love it. That's a great
and
reminder.
as far as how to handle this, our standard is to provide patients with their lab results at every visit. Now, some of them get their labs on our portal and don't necessarily want the hard copies. And occasionally, after many years, people are less interested in the hard copies. But we give them their lab results, and if I make changes, my sort of procedure typically is I write that stuff down.
Yeah.
And so hand it to you with, this is your homework. Okay. And basically this is your homework.
There's some homework involved in the process.
And because, and also let them look and say, okay, does this make sense to you?
Right.
Is this written in a way that it makes sense to you? And I think that gives us the best chance, because this is very complicated.
I was going to say, because that's my next question is really, how did you two work together to approach rejection prevention? That's, I can imagine, a really critical component. What you're really focused on is keeping a healthy kidney now that you have this transplant. So, Tiffany, what do you remember in terms of approach and, how it was relayed to you about how things were going to be moving forward?
I think, like she said, having an understanding of your labs, having an understanding of what your baseline is, and having basic knowledge. I think patients may, like you said, if you go to an appointment and you black out, you're not going to remember that she said, okay, your creatinine's kind of, creeping up. I want you to do A, B, and C, or we need to follow up doing D, E, and F. You have to be able to retain that information and, keep that open line of communication. So I think that's pretty key on discussing, any potential, rejection and things like that. And I think for her and I, pretty smooth sailing for the most part. But I know last year, I had some, issues come up, and it was a lot of testing and ultrasounds and x-rays and this and that, and then end up a biopsy. It was pretty crazy last year. And so with that being said, just being able to, confidently and consistently communicate and then have that understanding, because like you said, patients can't go into these appointments because the doctor is going to provide you with the knowledge. You have to be able to be the one to follow up and then, ask the questions that still remain.
Lead with that. I like the if there's something bothering you, lead with that.
Yes.
Dr. Corpier, I know anti-rejection medicines are important, and critical reminders of what to take and information that you share with patients like Tiffany. What are some of the things that you recommend when it comes to setting expectations around?
So we begin typically, in the pre-transplant period, setting these expectations. So our patients, my patients in the office now that we're getting prepared for transplant, even before they have their initial transplant consultation, we do education with them so that this introduces these concepts and make it very clear that in 2021, there is still a necessity for daily medication to maintain your graft. And then when they go for their transplant evaluation at whichever center they choose in the area, then they get another layer of education and then about that. And then before they leave the hospital, once they're transplanted, there is another layer of education about that. And then at pretty much every visit, then, tell me, do you have your medicines? Are you having trouble getting your medicines? And then are you taking your medicines? And then are you taking your medicines consistently?
Yeah.
And so it's a continual thing because, it's sort of like, we can't guarantee the longevity of a transplant, but I can guarantee you that if you stop taking those medicines, you will not maintain your transplant.
Yeah.
Okay. The people that get away with that are unicorns.
Yeah. Why test it? Why test fate,
Well, and I've told patients that exact thing. I tell them this experiment has been done many, many times. We are more than 50 years into kidney transplantation. I almost have to choke to say it, but I personally have been working with patients more than 30 years, okay? And the medicines have changed. Things have gotten much better. The surgical procedures are dramatically better. There's so much that is better than it was when I started my fellowship in 1987. But one thing that hasn't changed is the necessity for just meticulous management of your anti-rejection medicines.
Well, and you add another layer on top of that, and it's the food regimen and the diet that comes as a part of the lifestyle. And we talked a little bit about that, Tiffany, as well. But what are there's maybe an approved foods list, right, that you're given after surgery. What was your experience like with the approved list where, everyone's unique? But
Yes, I was going to lead with that. Everyone is unique. And so I've always, like I said, after my first transplant, I studied, got a holistic health coaching certification, all of that. So I knew that your nutrition is essential to the functioning of this kidney. But I feel that a lot of patients that I do talk to and mentor, that is their biggest struggle. That's their biggest struggle is understanding that these are the foods that, because, if they were on dialysis prior, I doubt that they were, following the food guidelines because, they just figured, oh, well, I'll go in and they'll flush my blood and I'll be fine. So this transplant, you're going to have to be responsible for maintaining those dietary restrictions and consuming the foods that you should, avoiding the foods that, could cause some issues. So I think that's a big issue. And it's funny you were talking about, patients listening and food, because I had a patient call me. He had attended some summits when I was with the NKF. Literally 2 weeks ago, he was calling me from the hospital before his transplant. When he got out of transplant, his wife called. He called me again. He's literally asking me questions, and the nurse is in the room with him telling him. And so I'm like, well, who's that talking? He's like, oh, that's the nurse. I said, well, she has all the answers. Like, she's right there. No, but I know, like, I want to hear from you. I want to hear from you. But I spoke, when we spoke earlier, that happens a lot. It's kind of like, the doctors are saying this, but what do you eat? Like, I want to know your diet. Can you text me? I got another new patient that she's going to be seeing. He's a former athlete and things like that. So he literally texted me yesterday, like, what do I take for my energy and what can I,
Yeah.
use to, I'm drinking coffee. I was like, you're not really supposed to be drinking coffee. You know that. And then he's
We're
like,
going to
so
double down on the importance of the relationship between patient and physician here.
yeah. I was like, and so then I literally went in my pantry and I texted him I said, these are all approved because you need to see a renal
Yeah.
dietitian. You need, you can ask me, but like she said, just that follow up and their understanding of how food is just so important. So,
Well, and there's an important piece too of this in terms of tracking it and how you're doing that. Is there a resource or a tool that you use to be able to do that?
as far as food or just in general. So we have at DNA, it's called My Health. I always forget the name
Follow
of
My
it.
Health.
Yeah, Follow My Health. And so with that, that's extremely helpful because she puts her lab, she puts her notes. If I want to know, did they call my new prescription in or my refill, it's all right there. So that's how you follow all of the medical advice and things like that. But as far as what you do for your dietary, I mean, there's a ton of apps out there that
Yeah.
people can use
Apps are your
to
friends.
to record. So whether you have an Android or iPhone, I would just suggest following, downloading something free. But for me, it's so routine. Like I almost eat kind of like a robot. It's like, these are my 3 options that I rotate for breakfast. These are my options that I rotate for,
Look at her,
lunch.
she's like, look at me.
And then for
Loves to hear
dinner,
it.
Yeah.
kind of the same thing because it's you're eating to live, not living to eat.
Yeah.
And so people have to get that concept. And yes, oatmeal gets boring. And yes, coconut yogurt, granola, and fruit. But you know what? You're healthy, you're active, you're staying in shape. So you just have to kind of make those sacrifices and make those adjustments and find ways to, if people, oh, well, I used to love, mashed potatoes and gravies. Okay, well, you got to do sweet potato and, you still get that
A new
carb.
version.
Yeah, and so just giving patients those options that it's a healthier alternative. So,
Well, and you talked about exercise. Oh, you go ahead.
Well, I was just going to say, I think, and this is a huge challenge in America, right?
Mhm.
I mean, I'll reveal some of my bias, but we are living in a toxic food culture, that
Yep.
is tends to be driven by, profit
Mm-hmm.
more than nutrition.
Mm.
And so, with our patients who have who have a range of kidney function and diabetes, hypertension. I mean, these are the common things that we're dealing with. Then trying to help them maneuver their way through all of these very sort of seductive
Marketing.
products and marketing
Yeah.
that are out there. This is very challenging. Most people are not as disciplined about this as Tiffany. The people who've been high level athletes, obviously, they're just at a different level of discipline than the average person. And but that's, so we have to be able to, and I think it's great.
Be honest
It's
with your
great.
doctor about
Yeah.
what you are eating.
It's-
That way they
yeah,
can at least still make good recommendations.
Yeah, I mean, the discipline is fabulous. And so, but I mean, if we can bring you, if we can just bring you out of, Jack in the Box and Taco Bell, sometimes that's the win we have to take. But we have a lot of support for our transplant patients in terms of our dietitians, and
Well,
they're invaluable.
There's another level of discipline here, and she talked about it, is exercise and her background as an athlete. But for the general population who doesn't have a background, as a professional athlete, or just even consider themselves someone who works out and does those types of activities, what are your recommendations for getting moving? What does that look like?
I think that we have to meet each person where they are.
Yes.
And so that's the main thing. And so in terms of managing hypertension, this comes under the lifestyle changes, and that's whether you've got normal kidney function and high blood pressure, or whether you're on dialysis, or whether you're a kidney transplant patient, right? So you can't go into the literature and find a downside to exercise. You can't.
Yeah.
And
We
so
may try to find it.
we
but-
may try, but you just can't find it. I mean, but the point is start start where you are. And if you're somebody that has not done anything, for 5 years, well, then you need to start at a very different spot than Tiffany or even me for that matter. I mean, I exercise. I try to exercise 5 times a week, and so sometimes I'm 4, but sometimes I'm 6. But I try to exercise every day because I have this tape in my head now. That's what's needed, and so what's recommended is 30 minutes a day, at least 5 times a week of walking. And and I tell people, if you can't do that, walk 10 minutes and then just work up. And, but I don't tell, I was talking to some patients before I came over here who are 80 years old, and they're like, well, we try to go to the mall and walk. Right. It's 100 degrees outside. I wouldn't tell an 80-year-old to get up and go.
My mom just got a membership at YMCA because they have a walk track that's inside and air conditioned. But something we also talk about is, instead of calling it exercise, calling it movement. Because sometimes you can get it in your mind where exercise is just this, you're not going to like it, you're not going to enjoy it. It's really just about moving your body and, what is it, inertia? Body in motion stays in motion, right?
Yes.
Just to work in all the phrases.
No, and I think that's an even better way to look at it. I mean that I was listening to an interview with a former model, another just of course beautiful physical specimen, right? That most of us aren't, and so we're asking, well, how do you maintain? And she's like, I just I try to move myself every day. She said something else than that, but that's what she was saying. She says and I try to break a sweat every day.
Yeah,
and walking to and from the TV in the kitchen does not cut it.
Well, I mean, COVID times in particular, are adding a different layer in terms of commute. If you're only commuting from your bed to your office space, I think it definitely requires just thinking about it in an extra way, trying to seek that out, because you're not necessarily walking into the office or doing stairs in a building potentially. So.
Yeah, but I think the other thing about COVID, the other thing about COVID too, is that when you are outdoors, the likelihood of, when you're outdoors, particularly by yourself, out walking, if you pass somebody on the street, your likelihood of catching that infection in those circumstances is infinitesimally small. Gyms are different, that's different, but outdoors is your friend.
Absolutely. Well, there's another layer of this, and especially around the immunosuppressants that we haven't talked about yet, which is how they affect your mood and how they affect you mentally, your disposition, I should say. From your experience, Tiffany, what are some things for fellow patients to keep in mind about this?
I think ensuring that, your body, but you don't know your body. Do you know your body?
Yeah.
So I think just being really, really tuned in to the fact of, why are my hands tingling? Why are my feet tingling? Why do I feel like I'm sweating more after I eat, whether it's spicy food or whatever. So I think that's something that patients have to start being more in tune with their body and understanding how food, lack of physical activity, and their moods affect them. So you asked about their moods, right?
Yeah.
And with the medication, that's something to discuss with the physician if you're feeling like, and for me, I've been on immunosuppressives for so long that I don't really notice the difference. But when you first start out, I mean, you're in the hospital and it's like a briefcase full of medications that you're given. And so just like with the appointments, over time, over the first 2 weeks, the first month, the first 2 months, all of that medication slowly starts to taper because you're, I don't remember all of the names, but some of them, that you take for a month.
Some of the infection prophylaxis is time limited.
Yeah.
If you're on steroids, the steroids are on a taper schedule. Yeah. And as far as the mood issues are concerned, I mean, sort of classically, the steroids have been the biggest issue.
Yes.
And
when you get that, when you're in the hospital, not to cut you off, when you're in the hospital and you get those high dosages, I mean, it's so much medication. So mentally, you're already like, this is way too much, and you got to do these in the morning, and then afternoon, and then at night, and then these are just in the middle. So I think mentally that affects your mood, just
Yeah.
knowing that you have so many medications that you're going to be putting in your body. And then as you taper them off, I think mentally your mood kind of lightens as your medication regimen lightens. And then once you get to that point of stability, of, some people, they may be lucky and they're just taking maybe, immunosuppression, 2 pills. Some people have high blood pressure pills. Some people have to take things for diabetics. Whatever underlying other medical issues you have, those are going to be part of your maintained regimen. But so I think that affects your mood just in general, knowing that it is so much that you're going to have to consume. I mean, I'm not exaggerating.
Yeah.
It's like a briefcase.
True.
It's,
Well, initially it's
It's a
very
lot.
hard, and
Yeah.
so some of the antiviral medication can affect a person's mental status. The prednisone in particular, the higher doses like tacrolimus, and then any of the side effects. And then the thing I wanted to add into this is sleep.
Mm-hmm.
And to the extent that people become sleep deprived, for example, I mean, it's gonna so the good news is you're going to make a lot of urine after the transplant. The bad news is you're going to make a lot of urine after the transplant. And so depending on the patient, for example, this wasn't Tiffany's experience because she was transplanted before she ever went on dialysis. So she never experienced what some of the dialysis patients do, which they may go years not making any urine. When that happens in the human body, then the bladder actually contracts. And so your ability, to how much urine your bladder can hold is far less. And so if once you're transplanted and you've got this beautiful kidney and it's just rolling,
Yeah.
right? It's rolling, and you might be making, 60 or 80 ounces of urine a day, but what if your bladder can only hold 2 ounces?
Yes, you're
Right?
you're losing
You can
sleep
do the
on top of
math
this. Yeah.
as to how many times you're going to go void.
Yeah.
And a lot of that's going to happen at night. And so people go through a transition with that. So there are a lot of factors. And then just the overlying anxiety
Yes.
of is this all going to work? Is this going to be okay? And, any pain, any early post-op pain, which is usually a pretty limited. That's not usually a long-term thing, but these other things can drag on for a bit.
Yeah.
And so yeah, it can definitely affect.
I'm glad you touched on all that because there are a lot of moving factors. I mean, everyone's situation is going to be different. Tiffany and I talked about the importance of community and being able to have a community of other patients who may be going through similar experiences to build on that. But this clearly between patient and physician is a collaborative journey. And, I can imagine on a lasting note, I wanted to talk about, I've heard the term, I think, adherent patient is what does that mean to you as a physician, Dr.
So
Corpier?
the language that had been used for a long time in our profession, in medicine overall, is compliance, right? And so that means somebody that does what you ask them to do, basically, that does what they're, quote, told to do, or takes their prescribed medicines, et cetera. So, compliance. And so then in the field, in our field, we, particularly in the dialysis arena, that is hard for a lot of people to do those things. And so then they can get labeled as being non-compliant. And then over the last decade or two, it's become clear, like, this can be pejorative. It doesn't really get at what's going on. Why is the patient not able to do these things? And so it's the language has switched to, we call it adherence. And so, can they adhere to the prescription? And then, the way I approach it, in whatever patient I'm dealing with, is if they're not, and it's clear, and if it's clear that they're not, and for transplant patients, we have drug levels for some of their medicines. And so, you can tell. And, and we check blood pressure. I mean, we can tell sometimes. And so my issue is always why. So help me understand what the problem is. And so sometimes the problem is financial. They can't get them, or they're having to stretch medicine. This has been in the news, prominently with diabetics, right? But sometimes it's because the patient is having a side effect, and they are attributing that side effect to a drug that may or may not be causing it.
Mm.
And so sometimes they get mixed up a little,
Yeah.
or they don't know, and they think it's, pill A when it's really pill B. And so, that's one of it. Sometimes it's because they're having cognitive issues.
Mhm.
I mean, sometimes it's because they're having family issues,
Yeah.
And so the issue is to then address it.
Yeah.
Okay. Because, we're trying to row in the same direction.
Absolutely.
And it's not I think that the old, sort of very old fashioned idea of, the doctor is removed, do what I say, you're on your own. This is not a modern way of at all or a humane way, in my
Right.
opinion, of approaching this. One of the reasons I do this is because I like the long-term relationship.
Yeah.
And so,
Well, that touches on, I would love to, on a lasting note, I would love your perspective, Tiffany, on just the importance of that relationship between physician and patient
I think it is.
working together.
Yeah, it's the most important piece of being a patient, but especially a transplant patient, because you have someone who is, one, has your best interests at hand and are doing everything they can medically to ensure that you keep this transplant. And so then you have to then ensure that you're doing everything within your power to also keep it. So it's the constant communication, and Dr. Corpier, I'll probably text her at a time or email her something, or I'm always sending her articles and what do you think of this and that? And she's always there to respond. But patients have to understand that relationship is great to have.
Mm-hmm.
And, I touched earlier about this amazing department that we have now with DNA called patient navigators. That's also a key element for, it's like, if you can't get directly in contact with your doctor because, they have, I don't even know how many patients you guys see in a day, but then you have someone that's not just the nurse, but also a patient navigator that can talk you through some of these things until you can, meet with the physician. So I just think, my relationship with Dr. Corpier has always from the beginning been so very unique. We are very, strong personality, strong-willed, and we both are very in tune with, doing research on something. And I know she does a lot outside of DNA at the Capitol and things like that. So it's always inspiring to know that you have a physician that's not just having you sit down, look at your labs, barely make eye contact. We get in there, she's relaxed, I'm relaxed. If she has to type something, she'll type, but it's like how we are here. And so, and people know that, not only if you see Dr. Corpier, but a lot of our physicians at DNA, have that same approach. And so patients have to understand, they are there to keep you healthy and keep you safe. So you can't go in being intimidated. You can't go in passive. You can't go in just saying whatever the doctor says, I'm going to do it. And then, like you said, leave and forget everything.
Mm-hmm.
So I think the patient-physician relationship is more important than the relationship you have with your spouse or anyone else, because this is the person that's keeping you healthy and alive. And so
I love it.
I can't,
That's
And
fantastic.
I would just add to I would add to it, though, it does with the patient navigators and also our nurses in our clinics and our other staff. I mean, it really does take a village.
Mm-hmm.
Like, this is not a one person show. I mean, this requires an enormous amount of help
Mm-hmm.
and commitment. And we at my office, we happen to have a patient navigator who has decades of experience in all aspects of transplant, dialysis, and chronic kidney disease care. My nurse is one of the best humans and nurses I've ever met. I mean, she just, she will annoy me to death to get things, finished if I'm dragging my feet.
Yeah.
And but I mean, we have the dietitians, the social workers that work with our transplant
Absolutely.
patients. I mean, our front office people. I mean, from soup to nuts,
Yeah.
basically.
Well, I think that's the fantastic theme for us to end on here, and I'm so grateful again for y'all's time. But really, rowing together is a rowing together, and that it does take a village, and really leaning on that in terms of support. Thank you, ladies, both so
Oh,
much.
of course.
It's fantastic.
Thank
Thank
you.
you.
Thanks for tuning in today. Learn more about Dallas Nephrology Associates at www.dneph.com. That's DNEPH.com. And if you found the information valuable, be sure to share with those also impacted by chronic kidney disease. Dallas Nephrology Associates DNA podcast series, Let's Talk About Kidneys, is provided for general information purposes only and does not replace the need to talk with a healthcare professional about your unique situation, care, and options. Our goal is to provide you with as much information as possible so you can be as informed as possible. Reference to any specific product, service, entity, or organization does not constitute an endorsement or recommendation by DNA. The views expressed by guests are their own, and their appearance on the program does not imply an endorsement of them or any entity or organization they represent. The views and opinions expressed by DNA employees, contractors, or guests are their own and do not necessarily reflect the views of DNA or any of its representatives. Some of the resources identified in the podcast are links to other websites. These other websites may have differing privacy policies from those of DNA. Please be aware that the internet sites available through these links and the material that you may find there are not under the control of DNA. DNA shall have no responsibility for the accuracy, legality, or content of the external site or subsequent links. Contact the external site for answers to questions regarding its content. The resources included or referenced in the podcast and on the website are provided simply as a service. DNA does not recommend, approve, or endorse any of the content on the linked sites. The content provided on this website and in the podcast is not medical advice and should not be used to evaluate, diagnose, treat, or correct any medical condition. The content is solely intended to educate users regarding chronic kidney disease, end-stage renal disease, ESRD, end-stage kidney disease, ESKD, and related conditions, and ESRD, ESKD treatment options. None of the information provided on this website or referenced in the podcast is substitute for contacting a healthcare professional.